Welcome to our first video on miscellaneous immune-mediated skin disorders. Let's begin. Here are the topics we're going to discuss in this lecture. Let's begin with urticaria. During our discussion on urticaria, we'll go through its definition, etiology, clinical features, diagnosis, and management. Urticaria is a vascular skin reaction characterized by transient, well-circumscribed, raised erythematous plaques, also known as a wheal, and flare reaction, where wheal describes the swelling caused by edema, and flare describes the surrounding erythema caused by vasodilation. The lesions are associated with marked pruritus. Acute urticaria is when urticaria is present for less than 6 weeks, whereas chronic urticaria is when urticaria lasts for more than 6 weeks. Coming to etiology. In most cases, urticaria is caused by an immune-mediated or direct mast cell degranulation. Common examples of immune-mediated urticaria are ones caused by foods or bee stings. On the other hand, opioids, radiocontrast agents, and vancomycin are known to cause urticaria via direct mast cell degranulation. Recall from step 1 that mast cell degranulation releases histamine, which then causes vasodilation and increased capillary permeability, leading to erythema along with superficial dermal edema. Note that in urticaria, there's no epidermal changes in contrast to eczema, which is characterized by epidermal spongiosis. Urticaria can also occur in the setting of certain infections, use of NSAIDs, and rheumatologic diseases. In many cases, it is idiopathic. Coming to clinical features. Urticaria presents with acute onset, that is minutes to hours, of pruritic, round, or serpiginous raised erythematous lesions. This is followed by progressive enlargement or worsening of lesions over hours. Individual lesions disappear within 24 hours with no residual scarring. Urticaria is usually a self-limited disease. Here's an image showing urticaria in a child. Note the characteristic round and serpiginous raised erythematous lesions. Although urticaria in itself is a benign self-limited skin reaction, it may be an initial manifestation of more severe and life-threatening hypersensitivity reactions, such as anaphylaxis and angioedema. Hence, it's vital to evaluate the patient for signs such as hypotension and wheezing, which indicate anaphylaxis, and swelling of lips, eyelids, and laryngeal edema, which indicate angioedema. Here's an image showing patients with angioedema. Note the marked swelling around the eyelids and swelling of the upper lip. Coming to diagnosis. Urticaria is usually a clinical diagnosis. To find the etiology, an allergen testing can be done. Lastly, although not usually indicated, biopsy of lesion can provide definitive diagnosis. The histologic features include dermal edema and perivascular inflammatory infiltrate. Here we can see histopathologic changes seen in urticaria. The solid arrows are showing dermal edema, while the dashed arrow is showing perivascular inflammatory infiltrate. Management of urticaria is supportive with avoidance of triggers and the use of H1 antihistamines. Glucocorticoids may be considered in severe cases. Let's do a review question. A 26-year-old woman comes to the physician due to an itchy skin rash for the past 4 hours. Before symptoms onset, she was at her friend's birthday where she ate cake with peanuts. Her vital signs are unremarkable. The physical exam reveals erythematous, pruritic, smooth plaques on the patient's torso. Lungs are clear to auscultation bilaterally. What is the best next step in managing this patient? This patient complains of an itchy skin rash for 4 hours. The physical exam reveals erythematous, pruritic, smooth plaques on the patient's torso. This is a classic description of urticaria. Given that she ate cake with peanuts several hours ago, her urticaria is most likely an allergic reaction to peanuts. Unremarkable vital signs and lung auscultation practically exclude anaphylaxis. The best next step in managing this patient with urticaria is H1 blockers, also known as antihistamines. Next, we'll discuss erythema multiforme. Alright, so erythema multiforme is a type 4 hypersensitivity reaction which presents with an acute onset of target or iris lesions. The lesions have the appearance of a target sign or a bullseye, hence sometimes called a bullseye lesion. Let's have a look. This image shows the classic target lesions of erythema multiforme. A typical lesion consists of a central erythematous macule or plaque, surrounded by a pale ring, which in turn is surrounded by an erythematous ring, thus forming a target sign. So the lesions have a central erythematous plaque surrounded by a pale ring and have an erythematous halo at the periphery. The exact pathogenesis is unclear, but is most common seen in association with infections such as herpes simplex and mycoplasma infections, drugs such as penicillin and sulfonamides, and rheumatologic diseases. The commonly involved sites are extremities, trunk, face, and the neck, with extensor surfaces of distal extremities being the most common sites affected. Oral mucosa may be involved in the more severe form of erythema multiforme, known as EM major. The lesions are usually non-pruritic and non-painful. Hence, they are generally asymptomatic, unlike the lesions of most other hypersensitivity reactions such as urticaria and Stevens-Johnson syndrome. Lastly, erythema multiforme is self-limited. Erythema multiforme is mostly a clinical diagnosis. Management includes withdrawal of the offending agent if feasible. Antihistamines can be used if lesions are pruritic. Glucocorticoids may also be considered. Lastly, EM major may need hospitalization. A 21-year-old man comes to the physician due to non-pruritic rash on his trunk and shins. He had an atypical pneumonia 2 weeks ago. His vital signs are unremarkable. The physical exam of trunk and extremities reveals central erythematous plaques, which are surrounded by a pale ring and an erythematous halo at the periphery. What's the difference between urticaria and this patient's current condition? This patient reports a non-pruritic rash on his trunk and shins. The physical exam reveals central erythematous plaques, which are surrounded by a pale ring and erythematous halo at the periphery. This is a classic description of a targetoid, also known as bullseye rash. Given that he's recently had an atypical pneumonia, presumably due to Mycoplasma pneumoniae, his rash is likely caused by erythema multiforme. Now let's compare erythema multiforme with urticaria. Erythema multiforme is an example of type 4 hypersensitivity reaction, while urticaria represents a type 1 hypersensitivity reaction. Erythema multiforme presents with targetoid lesions, while urticaria is characterized by evenly erythematous plaques. Finally, the rash in erythema multiforme can last up to a month, while urticaria usually resolves in 24 hours. Let's end our lecture with a board-style question. A 27-year-old woman comes to the physician due to a skin rash for the past 3 days. She finished a course of trimethoprim sulfamoxazole for uncomplicated cystitis 1 week ago. Her past medical history is significant for several episodes of anaphylaxis in response to bee stings. Her vital signs include a temperature of 36 degrees Celsius, blood pressure of 110/75, heart rate of 89, and respiratory rate of 17. Physical exam reveals erythematous plaques surrounded by alternating white and red circles on the shins and forearms. Lyme serology is negative. Which type of hypersensitivity reaction is most likely underlying this patient's current condition? A, type 1, B, type 2, C, type 3, or D, type 4. This young woman presents with a skin rash for the past 3 days. Physical exam reveals erythematous plaques surrounded by an alternating white and red circles on the shins and forearms. This is a classic description of a targetoid lesion, also known as bullseye rash. Lyme serology is negative, making Lyme disease an unlikely cause of this patient's bullseye rash. She finished a course of trimethoprim sulfamoxazole for an uncomplicated cystitis 1 week ago. Therefore, her rash is likely a delayed reaction to the sulfonamide antibiotic, causing erythema multiforme. Erythema multiforme is an example of a type 4 hypersensitivity reaction, so the correct answer here is option D. Here is a slide reminding us of the clinical features and high-yield associations with erythema multiforme. Let's discuss why other options are incorrect. Option A is incorrect because examples of type 1 hypersensitivity reaction include urticaria and anaphylaxis. Although this patient has a past medical history of anaphylaxis, her current vital signs are stable and her rash is different from urticaria, making anaphylaxis unlikely. Option B is incorrect because examples of type 2 hypersensitivity reaction include rheumatic fever, Goodpasture syndrome, and erythroblastosis fetalis, to name a few. Finally, option C is incorrect because examples of type 3 hypersensitivity reaction include diseases like systemic lupus erythematosus and post-streptococcal glomerulonephritis. And that concludes our lecture on urticaria and erythema multiforme.